Good morning or good afternoon, everyone, and welcome to 360DX webinars. I'm Julia Caro, Managing Editor at GenomeWeb, and I'll be your moderator today. The title of today's webinar is The Importance of Flexibility in Respiratory Testing Platforms, Accommodating Diverse Patient Needs and Changing Viral Incidence Throughout the Year. This webinar is sponsored by WholeLogic. Our speakers today are Dr. Rangaraj Selvarangan, who is a professor at the University of Missouri, Kansas City School of Medicine. We also have Dr. Jim Dunn, Director of the Medical Microbiology and Virology Labs at Texas Children's Hospital, and Dr. Matthew Binnicker, who's the Medical Director of the Clinical Virology Laboratory at the Mayo Clinic. You may type in a question at any time during the webinar, which you can do through the Q&A panel, which appears on the right side of the webinar presentation. And we will ask our speakers your questions after their presentations have concluded. If you look at the bottom tray of your window, you will also find a series of widgets that can enhance your webinar experience. So with that, let me turn it over to Dr. Selvarangan. Please go ahead.
Good day, everyone. Next slide, please. The topics I'm going to cover today are, first is a multi-center clinical trial to evaluate the Panther Fusion SARS-CoV-2 Flu A, Flu B RSV assay. And in the second half of the talk, I'm going to discuss some of the data that we generated using Panther respiratory panel pathogen assays for a surveillance project that we conducted in schools for respiratory viral detection, both in symptomatic and asymptomatic infections in children and staff from kindergarten to 12th grade. So to start with the first part of my talk, we will describe the findings from the multi-center clinical evaluation of the Panther Fusion SARS-CoV-2 Flu A, Flu B RSV assay. This was a clinical trial for this assay using nasopharyngeal swab specimens from symptomatic individuals for an FDA submission. The Panther Fusion assay subsequently received FDA clearance in May 2023. And this was published in Journal of Clinical Microbiology in November of 2023. There were 8 clinical trials, and they were spread across the country. And they participated in the study by enrolling specimens and performing testing. So the study included a salvage specimen protocol with both a prospective specimen collection and a retrospective specimen collection. Majority of the specimens were collected through the prospective specimen collection during the respiratory seasons, and 1,900 of the specimens were collected at each of the 8 sites participating. And this overall specimen number when enrolled was aliquoted into 4 different aliquots. The first aliquot was tested by the Panther Fusion SARS-CoV-2 Flu A, Flu B RSV assay. It was stored briefly at 2 to 8 degrees or frozen at -70 before being tested. The aliquot number 1 was tested on the EUA Cobas SARS-CoV-2 assay. Aliquot number 2 was tested on the EUA Aptima SARS-CoV-2 assay and the Panther Fusion Flu A/B RSV assay. These were the comparator methods that were used to compare the performance of the new assay. The third aliquot was used for PCR and bidirectional sequencing, specifically for SARS-CoV-2. And if additional sample was available and specifically for all the targets, then a EUA expert SARS-CoV-2 flu A B RSV assay was tested. Now, the study was conducted during the respiratory season when there were some of the flu A, B, and RSV were limited circulation. So subsequently, the sites augmented some positive flu A, B, and RSV samples to complete the trial. So there was 95 samples acquired through that mechanism. And these retrospectively collected samples were previously stored at -70, and they were tested by the Panther Fusion investigational assay, and also a confirmation aliquot was used for the non-SARS-CoV-2 target using the Panther Fusion flu A/B RSV assay. So here are the clinical trial results. As you can see, for SARS-CoV-2, overall, the positive predictive agreement was 96.9 for the prospective arm, and the negative predictive agreement was 98.5. And for influenza, including both the prospective and retrospective, the positive predictive value was 98, and negative predictive value was 99.7. For influenza B, which was in limited circulation, the positive predictive agreement was 95.2, and negative predictive agreement was 99.8. For RSV, it was 96.4 positive predictive agreement and 100% for negative predictive agreement. Overall, total positive predictive agreements were greater than 95% for all the 4 targets, and negative predictive agreement were greater than 98% for all targets. Similar PPAs and NPAs were obtained between the fresh and the frozen specimen groups. And the data for SARS-CoV-2 was obtained only using the prospectively collected samples. Now, when we looked at the overall CT values, which is obtained from the Panther Fusion assays, one could see that the true positive, as depicted here in the blue bars, are much lower, at least 2 to 3 logs lower than the false negative specimens. However, these false negative specimens were tested on alternate comparator assays, and 7 out of the 7 fusion false negatives also had high CT values by the Cepheid assay with greater than 33 CTs, and vice versa. The 8 out of 14 fusion false positives were positive by the Cepheid. In other words, when we had discordant results, it was due to high CT values indicate of low viral load. So overall conclusions for the clinical trial includes discrepancies were common when the viral load was low. And now that SARS-CoV-2 is becoming an endemic infection with a high transmission in winter, this new assay, the SARS-CoV-2 flu A/B RSV multiplex assay, is becoming a new tool for clinical laboratories for winter respiratory testing, especially during the winter months. This clinical trial demonstrated robust performance for the Panther Fusion assay for NP swabs in symptomatic patients, adding a new FDA-cleared diagnostic tool on a mid to high level throughput platform for respiratory testing. With that, I will change gears and talk to you about this surveillance study that we performed in school setting, known as School Kids. KIDS stands for Knowledge of Infectious Diseases in Schools. So overall, the objective was to enroll 800 children and 200 staff members in a large school district in North Kansas City School to determine the burden of respiratory viral infection. The goal was to understand the burden of respiratory viral infection in schools, to capture the overall burden in the children and identify opportunities for intervention and risk mitigation in the school setting with the goal of preventing absenteeism, loss of learning, reducing staffing shortages, and school shutdowns and severe outbreaks. So overview includes, we had previously performed a NIH-funded RADIC study to detect COVID-19 in children attending schools. That was well received. And when we had another opportunity to look for all respiratory viruses through a CDC-funded mechanism, we applied for that and were successful. So the CDC school kid study, infections in children is usually not well understood, especially the respiratory infections. While most of the infectious disease surveillance in children occurs in hospital settings, we really don't know what happens in healthy children in school settings. This lack of data is a barrier during the pandemic. So we wanted to understand infections in children, especially in family settings, school settings, and the community to help with some of the policy decisions for schools. So the goals were to determine the burden of respiratory viral infections in students and staff, both without symptoms and with symptoms, and also to determine vaccine efficacy for influenza and COVID-19. So this included two cohorts. One is the longitudinal surveillance cohort, where the 1,000 subjects that were enrolled, where we requested self-collected nasal swabs from the 1,000 subjects on a monthly basis for the following 6 months. And we also offered on-demand testing for children that were symptomatic during the study period. And so once the surveillance samples, the longitudinal surveillance samples were received in the lab, they were tested on the Panther Fusion assay, which comprised the IBD respiratory testing menu on a fully automated Panther Fusion system. So these were the mini panels that were used for testing. All of the IVD approved assays, the flu A/B RSV assay, the adenovirus metapneumo RV assay, and the parainfluenza 1, 2, 3, 4, and the SARS-CoV-2 assay, which was the EEO version, was used for detection. And we also included a laboratory-developed seasonal coronavirus assay that was used also in addition to the other IVD approved assays, and included an EVD68 specific detection and a human gene for internal control. So once the subject was enrolled in the longitudinal study, as I mentioned earlier, viral testing was conducted on a monthly basis, and the samples were received in the laboratory and tested. And if they were symptomatic, samples were collected during symptomatic stages, and also it was tested, but it was on a different platform for more rapid results on the same day. Now, we also obtained vaccine records and conducted interviews during sample collections. So here are the results from the CDC school kids study. Overall, we had a detections. We collected about 3,200 samples, and we had a 25% detection rate. And there was an increase in detection of viruses in the pre-K and elementary school compared to the middle school, high school children and the staff members. And when we looked at the survey, nearly from surveillance samples, nearly 28% of the children were truly asymptomatic, but another 37% of the so-called surveillance samples had at least one of the respiratory symptoms. And about 25% of the samples did not have a successfully completed survey. So overall findings from the school study included 3,232 surveillance samples. 27% were obtained from staff members and 73 from school children. And the student population was, half of them were from pre-K and elementary schools. And a median of about 4 specimens were collected on over the course of 6 months from all the study participants. And overall, 25% of the specimens were positive for any virus, and co-infections were detected in about 2.45% of the specimens. And a substantially higher percentage of pre-K specimens tested positive for compared with the staff members' specimens. And when you look at the graph, you see the overall percentage of detection for the different viral types. Rhinovirus was the leading virus, both in overall detections and both in the pre-K and elementary, shown by the blue bars, followed by seasonal coronaviruses. And adenoviruses were common in the pre-K and the elementary school. But the overall detection in the school children were much higher than what was seen in the staff members. And we did not detect any detection for the flu and RSV viruses during the study period. So the message from the school kid study is respiratory viruses common among students and staff of large Missouri school district. About 25% of nasal swabs tested positive for at least one virus. And schools can limit spread by encouraging up-to-date vaccination, hand washing, and covering coughs and sneezes, and by improving ventilation in schools. With that, I would like to acknowledge all the clinical trial participants, study sites, and Hologic for sponsoring the study, and the project funding sources is noted here, and then the funding for school kids were obtained from CDC. With that, I'll conclude my talk and turn over the podium to Dr. Dunn from Texas Children's Hospital. Thank you.
Thanks, Dr. Selvarangan. And thank you all for joining today. I appreciate the opportunity to speak. I'd really like to share a little bit of our experience with respiratory virus testing here at Texas Children's Hospital. And here are my disclosures briefly. And so let me start by telling you a little bit about our institution. We are a very large dedicated pediatric facility with quite a few admissions and emergency room visits every year. And historically, when it came to respiratory virus testing, we used to employ a number of different methodologies. Now here we're looking at some of our testing from more than 10 years ago. So at that time, we used to include antigen testing, direct immunofluorescence testing, and we also had conventional viral cell culture capabilities. We also did have molecular testing at that time, and we would use the old Prodessa assays, as well as a laboratory-developed rhinovirus assay. But this entailed taking the respiratory specimen and doing a nucleic acid extraction. We could use an automated nucleic acid extraction system. We would have to put a master mix together and then apply that to 96 well plate or light cycler carousel for the PCR testing, and in order to get those final results. So very, hands-on, cumbersome type of process, although, the assays performed quite well in terms of accurate target detection. And at the time, we had a couple of different options for how the molecular respiratory virus testing could be performed. During the winter months, when we would primarily expect to see flu and RSV, we had what we called the winter respiratory virus panel. And in that case, we would start with testing just for flu and RSV. And if any of those were positive, we would basically stop. We also did some flu A subtyping as well, if those were positive. But if the sample was negative for flu and RSV, we would then proceed to do testing for other viruses here, metapneumovirus, parainfluenza virus, adenovirus. Now, if that was positive, any of those were positive, we would stop. If those were all negative, then we would reflex to culture. So a lot of work here on each and every respiratory virus sample that came in for molecular testing. Now, during the summer months, when we would typically not see flu or RSV circulating in the community, we would offer a summer respiratory viral panel, which really just focused on parainfluenza and adenovirus. And again, if the sample was positive for either of those, we would stop additional testing. If it was negative, then we would also, again, reflex to culture in that case. And then, as I said, we also did have a rhinovirus laboratory developed test. And all of this testing, as I said, was required nucleic acid extraction, master mix preparation, and so forth. And so these were just batched on a daily basis, 6 days a week during this time period. Now, it was around this time that we really started to consider rapid molecular testing, particularly for flu and RSV. As I mentioned, these are the main viruses that we see during the winter months. And we felt like it would be very much more appropriate to get a rapid test that was accurate so that we could use antivirals appropriately or antibiotics if it was not a viral infection. And we could decrease some of that additional unnecessary testing by getting a quick, accurate result. And then this type of result can also be important from an infection control standpoint, particularly if we're admitting a lot of patients with respiratory virus illness. And the impetus for this change to rapid molecular testing really was impacted by what we saw during the 2013-14 winter respiratory season. So here on this graph, you can see along the x-axis is the month of the year. And then on the y-axis are the number of positives samples for that particular virus. So for example, in December of 2013, you can see here in red, we had a peak of influenza A, about 400 patients positive with influenza A. And at the same time in green, we were seeing a peak in RSV infection. And this was out of about 2,100 samples tested during that month. So almost a 50% positivity rate for either flu and or RSV. We did see some co-infections at that time as well because both viruses were circulating at a very high level. So you can imagine this was quite a concern from an infection control standpoint. If these patients had to be admitted, we were having a hard time quickly and accurately identifying those that might be infected because of the older test methodologies or more slow, cumbersome test methodologies that we were using. So we devised, after that winter season, we devised what we called a flu or RSV admission panel, which utilized the Gene Expert system for rapid flu and RSV testing. And this panel had reflex testing. If all three of those targets were negative, we would then go on and do additional testing for parainfluenza, metapneumovirus, and adenovirus using those same old Prodessa assays that I mentioned before. But now we were no longer reflexing additionally to culture in cases where they were negative by molecular testing. So this particular test, we wanted to make sure it was being utilized appropriately. And along with our emergency department leadership, we devised an algorithm for who would be most appropriate to get the rapid flu RSV PCR testing. So these patients that come in with respiratory illness to the emergency department where they suspect potential influenza infection, were seen by the providers. And if they had a fairly severe respiratory illness, or they were going to be admitted to the hospital, those types of patients certainly could get a rapid molecular test for flu and RSV. Those also who, what I call, met the CDC criteria, which are shown up here on the upper right hand of this slide. These would be those groups of individuals considered at high risk for complications due to influenza infection. So this would be children less than 2 years of age, older adults, pregnant women, patients who are immune compromised, patients with asthma, chronic lung disease, or a very high BMI. So that's just a partial list of those high-risk types of patients. But if this patient coming into the emergency department met those criteria, or they were going to be admitted to the hospital, then yes, we would go ahead and do the rapid flu RSV admission panel. And oftentimes those patients might get their first dose of antivirals. And if that rapid PCR result was positive, they would continue to treat for flu. If it was negative in that case, then they could discontinue treatment for flu. Now, if a patient came in but didn't meet those criteria, the testing in that case was really not warranted. So they might get treated empirically depending on the duration of symptoms. If they had only had respiratory illness for less than 48 hours, they might be empirically treated for flu. And beyond that, they may not get any empiric treatment. So we implemented this the following winter season in the emergency department. And then subsequently, a year later, we went back and looked retrospectively as to how well they were utilizing this particular algorithm that we had developed. And during that subsequent winter, we had 682 emergency department patients that had the rapid flu RSV PCR testing. About 17% were positive for flu, about 5% were positive for RSV, and about 17% were positive for one of the other viruses. Remember, because it reflexes to the other respiratory viruses if it's negative for flu and RSV. Now, of those, about 65% were admitted to the hospital from the emergency department. So that those patients met the criteria for the rapid PCR testing. About 30% were discharged from the emergency department, but met one of those CDC criteria. Excuse me. So these would be the younger patients, less than 2 years of age, immune compromised, patients with sickle cell disease, or underlying medical conditions, neurologic conditions, metabolic disorders, and so forth. So we really had very good adherence to this algorithm at the time. Only about 5% of the patients that got the rapid PCR were those where testing probably would not have been indicated. So about overall 95% compliance with the algorithm. A couple years later, when the Panther Fusion platform was available and the respiratory viral mini panels became available, we took a look at this particular system because these panels were modular. They were specific to those individual targets in the mini panel format. So we could run 1, 2, or all 3 of these mini panels on the Panther Fusion system. And it would really fit into our testing algorithm that we already had in place. And this would allow us the flexibility to do some of that seasonal testing based on the epidemiology of the respiratory viruses at the time. And we could take one sample and do a nucleic acid extraction on the system in an automated fashion and apply it again to one, two, or three, all three of those mini panels on the fusion. At the time, we did a fairly thorough evaluation of the system using our own previously characterized respiratory samples. And you can see here for each of the mini panels, we had very good overall positive and negative % agreement for all targets. And so we essentially kept the same type of algorithmic testing that we had previously, but now we could apply the use of the fusion assays into that algorithm. And this began in 2018. So we still did have the rapid flu RSV testing capability on the GeneXpert. And then we also still had the winter respiratory viral panel option as well. And then the reflexive testing, if all of those targets were negative, then we could, because of the flexibility of the fusion system, set up the other mini panels for the adeno, metapneumo, and rhinovirus, as well as the parainfluenza 1, 2, 3, 4. And so we kept the winter respiratory virus panel, and we also added what we call a respiratory viral panel, which is all three panels run together. So for some patients, it may be important to test for all viruses at the same time. And so this could be done by taking that single sample from that patient and running all three mini panels. And then likewise, to what we had previously, we also had the summer respiratory panel, which really focused on testing just the adeno, metapneumo, rhino, and parainfluenza viruses. And pre-COVID, we would generally have fairly predictable respiratory virus seasons, right? So during the winter months, such as November, December, and January, we would expect to see here, this is data from almost 10 years ago, we would expect to see in green a lot of RSV, in blue we would see flu, usually around the same time or overlapping with RSV. But then in the summer months, we wouldn't really expect to see flu or RSV. And you can see here in the inset box, we didn't see a lot of respiratory viruses during that time, but what we did see were mostly adenovirus, metapneumovirus, and parainfluenza viruses. Now, COVID kind of shook things up quite a bit. So we saw some different patterns of our respiratory viruses, but during this last winter, we did see some of our older patterns where we saw RSV, for example, start late in the fall. Here in the green, you can see that we had a lot of RSV, which was then followed by a peak in flu A as well as flu B as we got into December and January in the dark blue and the red. In the light blue, rhinovirus we've seen at fairly high levels throughout the year. And we did see a slight peak of SARS in February as well. But now as we're getting into the summer months, April, May, and June, again, we're not really seeing a lot of flu RSV. There is some COVID that we're seeing, but we're primarily seeing some of these other respiratory viruses like adenovirus, metapneumovirus, and parainfluenza virus. And then more recently, we've now included the new fusion SARS, flu A, flu B, RSV assay. You saw the data from the large clinical trial that Dr. Selvarangan presented. We also did a small verification of this new assay in our own laboratory here, and you can see even though they're small numbers, we had very good agreement with our existing testing for those targets. So now our current algorithms for testing are, again, essentially the same, but now along with the SARS that's available on the Gene Expert assay, we now use the Panther Fusion assay with our winner panel, now includes SARS. Our respiratory virus panel now includes SARS as well, and then we still have the summer panel available as well. So really, this platform and these assays have really allowed us to pick the right test for the right patient. And again, depending on the time of the year, we may want to focus on particular viruses, and we can do that with this flexibility. And that really plays into the aspect of diagnostic stewardship, where we hopefully can optimally influence clinical care and conserve healthcare resources. So it's really important to remember that these test methods that we're using now for respiratory virus diagnosis need to have very, very high performance characteristics, need to include all the targets that might be necessary for our patient population. And with the flexibility of the Panther Fusion and the random access capabilities and the performance characteristics, we have been able to do the type of testing that we need for the different types of patients in our hospital system, and do that in a cost-effective manner. So thank you very much, and I'm going to pass it on to Dr. Binnicker at this time.
All right, thanks, Dr. Dunn, for the great overview and presentation. I'm Matt Binnicker from Mayo Clinic, and I just wanted to kind of wrap things up by providing an overview of how we approach diagnostic testing for respiratory viruses at a large academic medical center and reference laboratory. So because we serve both patients who are arriving at our outpatient and inpatient clinics, but also patients around the world through our reference lab, it creates some diagnostic challenges in terms of the approach that we would take to accommodate many different types of patients. So just a few disclosures. I'm an advisory board member for DiaSorin Luminex, and I have received honoraria for several educational webinars. So again, as I mentioned, accommodating respiratory virus testing for a very diverse patient population can be challenging. And what I'll talk about today is our approach. There are many different strategies towards diagnostic testing for respiratory infections. Many of that is dependent on your patient population, what tools you have in your laboratory, the volume of testing required. So all those factors are going to need to be considered in determining which systems you're going to bring in, which tests you're going to utilize, and the algorithm that you'll ultimately follow. At Mayo Clinic, we have multiple locations throughout the United States, but our primary headquarters and center is in southeastern Minnesota and Rochester, Minnesota. We have a 2,100 bed hospital that's a level 1 trauma center. We accommodate both outpatient care in our local community, as well as inpatients in our hospital facilities. We have a cancer center, so we're caring for highly immune suppressed patients that would include transplant patients. And we also care for both the adult population and pediatric population. So you can see from this diverse scope of the patients that we're caring for, you really can't offer a one-size-fits-all type of approach for testing for respiratory viruses. You either need to offer many different types of tests and utilizing different platforms, or utilize platforms that accommodate for flexibility. We also have our reference laboratory. So it's a global reference lab that services patients and clients around the world. We have over 4,000 clients worldwide. So in terms of our decision-making for respiratory testing, We convene a team about this time of year each year, so in the July-August timeframe, and discuss the upcoming respiratory season, what diagnostic tools we currently have available in our laboratory, and then make decisions about the algorithm to follow. That team is composed of providers from our infectious diseases division, members of our clinical microbiology leadership team, physicians and providers from primary care, and also from our information technology team, because it can become quite complex to build the different custom ordering profiles within our electronic medical record. And so we want to include them up front to get started on any build work in the electronic medical record system, as well as our laboratory information system. And then using this team, and we meet really over the course of several months, we establish algorithms for the adult immunocompetent population, in other words, otherwise healthy individuals who would most likely be seen in the outpatient setting, the pediatric population, and then what I'm going to show you is an example of an algorithm that we developed for our adult immunocompetent population in 2022. That algorithm remained largely unchanged for 2023. And so what we do is we have a nurse's line that has a number of questions that when patients call in, they go through those questions. And it starts with, has the patient had a flu-like illness in the past 48 hours? And if they have, we actually ask them if they have access to a COVID-19 antigen test. I've said this in many talks, but over the last 3-4 years, I never would have thought that I would promote asking, have you taken an antigen test first? But we're in a very different day and age than we were in 2019 and before. And so we asked that question, do you have access to a COVID-19 antigen test? And if the answer is yes, we recommend that they take that. Now, if the COVID-19 antigen test is positive, they are diagnosed with COVID-19 if they have compatible symptoms, and they're connected with the team for treatment decisions. Now, you might ask, what about the possibility of co-infection? And the possibility of co-infection with COVID-19 and, for example, influenza, RSV, or another respiratory virus is there, although we know today that it's not as common as we thought it might be in 2020, 2021. If they continue to worsen while they're on COVID-19 specific therapy, we recommend that they go in for additional testing for other viruses. Or if they fall into a higher risk category, we may recommend that they have additional testing. If either their COVID-19 antigen test was negative or they didn't have access to one, then we would ask the question, does this patient have risk factors for complications from respiratory syncytial virus? And so patients who might be at risk for more severe disease from RSV are, of course, young children, those greater than the age of 65, those with a high BMI, those who are immunocompromised, those who are or may become pregnant, as well as a list of some other medical conditions that would put an individual at higher risk for complications from RSV. And if they have complications or potential complications to more severe RSV disease, we would funnel that patient sample to a test or tests that would look for COVID-19, flu A/B, and RSV. And at the time in 2022, we had to accommodate this with multiple tests, 2 different tests that would look for COVID-19 and flu, as well as another test that would look for RSV. Now, if they didn't have complications or risk for severe RSV disease, we would just direct their sample to a COVID-19 and flu panel on a single platform. We still do get a pretty high volume of unique requests for COVID-19. And so we would offer a 3rd test that is only a COVID-19 emergency use authorization test for patients who are needing only COVID-19 only. So this year in 2024, the algorithm has stayed largely the same in that we are first recommending a COVID-19 antigen test if the patient has access to one. And if they test positive by that, we're diagnosing them with COVID-19. The difference is we ask the question about whether the patient has risk factors for complications from RSV disease. And dependent on the answer to those questions, we will route their sample to the same commercial 4-plex assay that has the ability to offer up different combinations of the testing using the same platform and the same test. We've basically created 3 separate orderables from that 4-plex panel that's all run on the same system that can accommodate whether a patient might need testing for all 4 viruses, just COVID-19 and flu, or they've already been tested for COVID-19. We really just need to look for flu and RSV. So this has much simplified our strategy in terms of routing samples and testing by utilizing a commercially available 4-plex assay that offers the capabilities for some unique ordering and masking of results. We again still do perform quite a few COVID-19 tests, and we will route those samples to the single COVID-19 emergency use authorization tests because the price per test for the COVID-19 EUA still is lower than for the commercial 4-plex assay. So just some additional considerations that I wanted to cover is that is the situation what I just covered for outpatients who are seen in our hospital setting or primary care. But if a patient is seen at our urgent care sites, and we have several of those in Rochester, Minnesota, or in our emergency department setting, we do have commercially available FDA-cleared point-of-care molecular panels that look for COVID-19, flu, and RSV. And those are performed because they provide answers in 15 to 20 minutes. Those are low throughput platforms, so they're able to keep up with the urgent care and the emergency department setting, whereas our central clinical laboratory is set up with higher throughput systems for our reference lab and our larger outpatient population. If a patient is presenting to their primary care, those swabs, as I mentioned, are being sent to our central clinical laboratory, described on the prior slide. And we do utilize multiplex molecular panels, but we try to be a bit more judicious about when those tests are performed. So in our immunocompromised patient population, we recommend that the physician consider a larger multiplex panel that would include other viruses that may be causing the patient's disease. And in our outpatient setting, if the patient tests negative by COVID, flu, and RSV, and they continue to worsen, they always have the option of looking at a multiplex molecular panel as well. It's just not recommended upfront. So I just wanted to finish up here in our last few minutes before we open it up for question and answer by giving kind of the crystal ball into what might happen in this 2024-2025 respiratory season. And we can do that by looking at what is occurring in the Southern Hemisphere. So as most of you know, our respiratory virus season in the United States and in the Northern Hemisphere typically occurs between November and April each year. It's the exact opposite in the Southern Hemisphere. If we look to countries like Australia, they are in the midst of their influenza season right now. And here are some data from Australia on lab-confirmed influenza cases. And you can see that over the last month, the incidence of influenza has spiked significantly. The majority of the positive cases have been untyped, but of those that have been subtyped, H3N2 makes up the majority of the typed influenza A's. And then the 2009 H1N1 has also been identified in a smaller percentage of cases. Talked with some colleagues in Australia, and they're really indicating that it's a severe influenza season. And so they've given the heads up that this could be a moderate to severe influenza season coming up in the United States and in the Northern Hemisphere. As is typically the case, influenza B will likely start to increase in prevalence in Australia as the influenza A season winds down. Here in the Northern Hemisphere, we typically see influenza B start to increase in prevalence, usually in the late February, March timeframe, as influenza A cases start to decline. Again, if you just go online and do some search for the status of influenza in the Southern Hemisphere, you will come across a number of stories recently just highlighting the significant increase in cases over the last few weeks, the increases in emergency department visits, and unfortunately the increases in deaths associated with influenza. So I do think this is the right time for us to be planning for testing and the strategies that we're going to follow here in the Northern Hemisphere, because it looks like it may be a moderate to severe season coming up here in 5 or 6 months. So just to summarize things, we now have multiple methods. We have targeted molecular tests that look for flu and RSV. We have antigen tests, especially for COVID-19. And we have small and larger multiplex tests that are available to diagnose these respiratory virus infections. There's no one perfect approach. There are multiple different options for you to choose from, depending on your patient population and the volume of testing you're going to be performing. That strategy you use is largely patient dependent and site dependent. Testing for COVID-19, flu, and RSV is usually required due to the overlap in clinical presentation. As I mentioned, from our algorithm, we ask some questions about whether the patient is at risk for more severe RSV disease, and then if they are, we include that in the initial testing. If they're not, then we typically at least just go for COVID and flu for the initial round of testing. Tests and platforms that include these targets and allow for flexibility in ordering, I think, will become the thing of the future. Our physicians are really asking for this. We want some flexibility at the time of ordering, depending on the patient that we're seeing, dependent on their clinical presentation, dependent on what tests they might have had done before. So those types of systems and assays that accommodate that flexibility are good not only for the laboratory, but for the physicians and patients that we're serving. So we'll stop there, open it up for the panel to ask questions that you might have. And thanks again for joining today, and for Hologic and Genome Web for the invitation to present.
Yeah, thank you very much, Dr. Binnicker, and thanks actually to all our 3 speakers, very insightful presentations. So let's see what we have here in terms of questions. We have questions for all 3 of you. Let me start with Dr. Dunn. You mentioned that you do flu A subtyping. Why is that a need to do that?
Well, that's thank you for the question. Yeah, that's somewhat historic. We no longer continue to do the flu A subtyping. Okay. So at the time, probably more than 10 or 12 years ago, it could be important to know, not only for epidemiologic purposes, but in some cases for treatment purposes, if it was a pandemic H1 2009 strain, or H3N2 strain versus the old H1N1 strain, which would be Tamiflu resistant. So, there were historically reasons from a treatment standpoint as well as an epidemiologic perspective to know the subtypes. But we no longer do the flu A subtyping.
Okay, thank you. A question for Dr. Binnicker. Do you offer any guidance to clinicians regarding which of the hologic assays to use, given their patient symptoms and their history? And what trends do you see in ordering of these different panels throughout the year?
Yeah, we do post our recommended testing algorithm on our lab test catalog. Our physicians have access to that. We do also provide some education to our physicians on the testing that we offer, again, which can change season to season, which panels that we're offering, and then when they might want to order those different panels dependent on their patient's clinical presentation. Many of our outpatients who are calling in will get a hold of a nurse who will triage the case, and that testing stewardship team that I mentioned, ID, primary care, clinical microbiology, will come up with a pretty extensive question and answer list for the nurses to walk through with the patients that helps to ultimately guide them towards which panel of tests to order up.
Okay, thank you. Here's a question probably for all three of you that's top of many people's minds today. Is there a need for flu H5 or bird flu testing going forward?
I have my opinion, but I'll hold it off. Maybe Raj, since you haven't had the
Raj,
chance
you want to go ahead?
Yeah, sure. Certainly, it's good to have the option to do a H5 subtyping, but not to roll it out unless and until you see circulation of those viruses.
Right.
So it's always good to be prepared and ready, but not to deploy those tests unless and until you see circulation. Or at least in one location right now, if you see this is in Texas, then other locations need to be ready and do some surveillance. But for clinical purpose, you need to really be sure that those viruses are circulating so we don't have false positive, and false alarms can cause quite a bit of a panic across the entire system.
Okay. Anyone else want to chime in? I
hope Matt has the same opinion. I don't know. We'd like to hear this.
Yeah, no, I agree. It's probably, we're not to the point where we should open up H5 specific testing and subtyping for every sample that we would test for flu A and flu B. What that situation will look like in a month or two, it's impossible to know, but we desperately need the tools to be able to subtype for H5 and maybe even H7, because this problem likely isn't going to go away. And having the tools in clinical laboratories is going to be really important. I would say right now, we mainly would need to use them in individuals who have had the right exposure history, those working at poultry or dairy farms who would present with conjunctivitis or respiratory disease. We need those tests. But that may change in the next weeks or months to be much more broadly needed.
Okay, thank you. And maybe one more question for Dr. Dunn. The high levels of rhinovirus you saw in 2023, do you expect them to persist in the future?
Yeah, we do see a fairly high rate of rhinovirus detections. I don't know the exact percentage, but in a lot of those instances where we do detect rhinovirus, it's often along with another respiratory virus. So it's associated with co-detection of other respiratory viruses. So that could be parainfluenza and rhinovirus, or COVID and rhinovirus, and so forth. So in many instances, it's a co-detection. But I do expect that we're going to see fairly sustained levels of rhinovirus detections. Now, as to whether that virus by itself is causing significant disease, I have some reservations about that, in a lot of patients as to whether it's clinically significant.
Okay, great. Thank you. That's unfortunately all the time we have for questions today. So let me thank our speakers, Rangaraj Selvarangan, Jim Dunn, and Matthew Binnicker, and our sponsor, Hologic. And if we didn't have time to get to your question, we will try to have somebody follow up with you via email. As a quick reminder, please look out for the survey after you log out to provide us with your feedback. And if you missed any part of this webinar, you would like to listen to it again, we will send you a link to an archived version. So with that, thank you very much for attending this 360DX webinar.